Good evening. I'm Dr. Gisela Trajano Sarmiento, and I would like to thank Novo Nordisk for having me as their key opinion leader for tonight. And my topic is going to be understanding obesity and the importance of appetite regulation, which is a very, very timely topic, especially now that it's the pandemic. Okay, so the objectives of this is to discuss the burden of obesity, the importance of appetite regulation, and liraglutide for weight loss. So obesity is actually a global pandemic, and we know that more than 650 million population worldwide is suffering of obesity. A lot of the global organizations right now agree that obesity is a chronic medical illness, and it is defined as an abnormal or excessive fat accumulation that may impair health. So it can impair your functioning, it will present a lot of signs and symptoms, and it can present also with a lot of harm and morbidities. To put it into perspective, obesity can be viewed as the root of a lot of diseases. So not only as an increased mortality, but of course it's also associated with significantly increased morbidity, which can be affected by the daily activities of daily living, and of course it affects almost every organ system. So it can be metabolic, mechanical, and mental. For your metabolic, you can have asthma, and of course your non-alcoholic fatty liver disease, gallstone, infertility, cancers may also be presented. Of course, there's an increased risk for the cerebrovascular illnesses, stroke, dyslipidemia, hypertension, coronary artery disease, congestive heart failure, pulmonary embolism, and of course type 2 diabetes, thrombosis, and gout. For your mechanical, there can be also be presenting physical functioning as your incontinence, arthrosis, sleep apnea, chronic back pain. And of course, for mental, there will always be depression and anxiety. So it's actually a conglomeration of a lot of this. So obesity is a major risk factor for severe COVID-19 infection, especially right now that we're on ECQ once again. So what do we know so far about obesity? It increases the risk of severe illness from COVID-19. It triples the risk of hospitalizations due to a COVID-19 infection, and it is linked to impaired immune function. It increases the body mass index which decreases the lung capacity and the reserves of the lungs and can make ventilation more difficult. And that is what is being presented by almost all of our COVID-19 patients are stricken right now. And as the BMI is increased, you'll see that the risk for death from COVID-19 increases as well, as much as actually 48% for patients with obesity in the Philippines. And there are also a lot of journals presenting the percentage in other countries. Studies have demonstrated that obesity may be linked to lower vaccine responses for numerous illnesses like your influenza, your hepatitis B, and of course tetanus. And all of this may potentially impact the response to your COVID-19 vaccines. So as such, locally, updated data from the DOST from the DOST LFF NRI, which shows that the prevalence of obesity among adults has increased further from previous 31.1% to 37.2%, and which now makes approximately about 4 out of every 10 adult Filipinos as having pre-obesity or obesity. So do note also that this survey used the WHO Body Mass Index, which is the cut-off points, and which means that if we base it on the Asia-Pacific guidelines, then this number would be most probably even higher. Look at the National Capital Regions, about 39.9%. Cebu and Central Visayas, 30.1%, and the Davao and Northern Mindanao is about 32%. This is actually classification of your BMI as to your normal, pre-obese, obesity class 1, class 2, and class 3. So you have this table that will always guide us as to the WHO and the Asia Pacific classification. So with that, I would like to continue. The Philippines right now on lockdown is one of the things that we are taking care of right now. In the past 6 months or so, we have been under various stages of lockdowns or community quarantine in our effort to curb the rise in the COVID-19 infection. So generally speaking, dear doctors, what we should be doing at this time are, of course, we tell our patients to eat a healthy diet, being active, getting enough sleep, coping with stress, because there's so many mental ailments right now. But however, for most Filipinos, unfortunately, there are challenges in achieving this because there's always loss and the lack of income, especially this poverty line. This contributes to inability to acquire and provide the nutritious food. And of course, stress from working at home and our boredom, if you're unemployed, contributes to increase in food intake. There's also limitation in mobility, which prevents adequate exercise and access to food. Thus, these unhealthy lockdown lifestyles have contributed to rise in obesity, and we see that in our patients, in our family members, and our friends, and the weight gain that may potentially increase the risk of the severe COVID-19. Hence, obesity should actually be a priority during the COVID-19 pandemic. So look at this. This is actually a complex multifactorial disease, which is obesity. It has long been misunderstood, trivialized, and stigmatized as a simple lifestyle. It's an issue that can be effectively addressed by the mantra of eat less, move more. But this simplistic view of obesity disregards both the lived experience of persons with obesity as well as the vast body of scientific evidence. It shows that actually that like other chronic ailments, obesity is a rather heterogeneous condition resulting from the complex interaction of a multi socio-psycho-biological factors that promotes excessive weight gain and ultimately impair health, just like what this particular slide is showing. So most importantly, you'll see that once established, our powerful neurohormonal factors effectively defend our bodies against weight loss, and thereby often making obesity a lifelong problem, where weight gain, or of course the relapse on this weight gain, is the rule rather than exception. So there's an imbalance between energy intake and energy expenditure. You'll see that under normal circumstances, long-term energy balance is centrally regulated by the brain. You will see that here. It receives the peripheral input from the adipose tissue, the pancreas, and the gut on energy stores and nutritional state via neural and endocrine pathways. Now, there's the imbalance in energy intake, and expenditure can result from changes in these peripheral signals as well as from genetic predisposition and impact of medications. So, on environmental, nature, societal, and psychological factors together with the pleasure we derive from the food, or we call hedonic factors, that will influence the energy balance and which in turn can lead to weight gain. Although it is well established actually that obesity is the primary driver of many chronic ailments, such as cancer, as what we discussed a while ago, that obesity is also a chronic disease in itself. So what are the challenges actually? What are the challenges actually of this? So there's inactive lifestyle, smoking cessation, and psychological factors, increased palatability or pleasure, and that is your hedonic. So the challenge is actually obesity in general is actually an energy imbalance. So you will see here that as a result of energy imbalance, wherein energy or food intake more often than not outweighs energy expenditure. So you will see that it's not as simple as this, wherein the causes of obesity are really multifactorial and may involve genetic, psychological, socioeconomic factors, environmental issues, as well as the culture. So energy expenditure, energy intake. So we address this with diet. We also address this with exercise. But in reality, it is really not as simple as this is. So the challenges right now is how much weight loss really is acquired to reduce this obesity related complications. So studies have shown that a 5 to 10% weight loss in 3 to 6 months, as this slide depicts, can reduce risk for progression of type 2 diabetes. It also reduces actually risk for your cardiovascular health, or death rather, and of course improve blood lipid profile and blood pressure. So it will also improve sleep, apnea symptoms, and improve overall health and related quality of life. For most individuals, actually, lifestyle modification is the first choice of treatment. So you have the diet, wherein we need to reduce the daily caloric intake by at least 500 kilocal, and that's per day. And of course, bound with exercise, about 20 to 30 minutes of mild to moderate exercise per day, or I'll tell my patients at least 30 minutes of about 2 times a week. And primarily, this is a treatment option for weight loss for patients with obesity. But the problem is sometimes diet and exercises are not enough. Even especially if you have this class 3 obesity rank, the severe obesity, they have this very, very big frame as an endomorph, and it happens to be really burdensome for them. So with that, we go further. Alright, so the challenges with the current weight loss. So you will see here that the challenges are actually this one. So given the options that we have, these also come with their associated challenges. For diet and exercise, you will see that the challenges lies mostly on the initiation, of course, which is always the hardest step. And making patients commit to diet, exercise, and lifestyle changes takes a tremendous amount of willpower. So for those who will be requiring pharmacotherapy, another challenge lies in options. So meaning, currently in the market, we only have two options, if you know. There is actually the orlistat, and which is known for its fatty diarrhea or the steatorrhea, since it causes malabsorption of fat and of fat. And of course, we also have the pentermine, wherein this is a derivative of amphetamines. It requires an S2 license though, and is known for its central and cardiovascular side effects and cannot be used for patients with known heart complications. So surgery, on the other hand, is expensive and complex and is not suitable for all patients with obesity. So we always ask our cosmetic surgeon, well, who are the proper candidates for this particular surgical intervention. So furthermore, there's an issue of weight regain. Regardless of intervention, patients often seem to regain back pounds lost within 2 years. So that is the problem that lies also. So what makes effective weight loss difficult? So the brain sets a weight set point that it wants to protect actually, and this weight set point may be really abnormal. So diet and exercises can help you lose the pounds, but the brain will try to counteract the weight loss through adjusting metabolism and the regulation of appetite. So on this particular slide, you will see that there is a need for significant, sustained, and safe weight loss option that targets appetite regulation to prevent the weight regain. So we really don't want the Nike effect. We don't want the yo-yo effect, the syndrome, as we lose the weight. So this weight regains follows any weight loss intervention. So we can see here the differing weight change pattern for diets of different intensities. A very low calorie diet with behavioral therapy may provide, you'll see here that it can provide actually rapid initial weight loss that exceeds the weight loss achieved with a very low calorie or modified diet plus behavioral therapy. But however, looking at this slide, alright, the benefits disappear over the long term. And by 5 years post-intervention, you will see that there is little difference between the diet types, with mean weight change back to the baseline level actually for all diets. So that's the sad thing. Another one, this one, look at that. Intervention stops, alright, then you'll see that the weight change goes back to the baseline level of all diets. So let me discuss on the homostatic versus hedonic regulation of appetite, because we need to understand what is really the culprit, why we really want to eat, why do I love to eat at 45 years old. Alright, so there's homostatic regulation, there's hedonic, and there's environmental. So these are actually biological systems that acts to maintain body weight. So it regulates peptide hormones that can induce hunger and satiety under homeostatic regulation for the balance. It changes in energy expenditure. If you're going to exercise, you're going to exert effort, your muscle will contract, and then it will produce a lot of heat that will now go to the subcutaneous layer on top of it. Now for hedonic regulation, this is actually the reward of survival behavior, so such as sex or eating through pleasure. So it operates even the presence of satiety signals. It can lead to food consumption beyond homeostatic need, and it's a link between hedonic attraction to your high calorie food and actually your obesity. Alright, so let's discuss this really well. So the brain is responsible for maintaining the body's metabolic set point and through our appetite of energy intake. So let's see. Alright, so this one, actually the brain controls eating behavior and appetite on 3 levels. So I said homostatic, alright, wherein it is the balance between feelings of satiety and hunger. Now this one is actually mediated by your GLP-1, your peptide, one, and then of course your oxyntomodulin, pancreatic polypeptide, and your amylin, and the hunger is mediated by your ghrelin. Your hedonic eating, on the other hand, is eating based on pleasure and is mainly under mesolimbic control. As I've said, the feelings of wanting or liking to eat, that this is actually us all the time. A want to eat is mediated by dopamine, actually, which is a hormone implicated in the reward behavior system, and this is actually responsible for cravings that we have, like for example, when we crave from milk tea in the afternoon after a day's work, or at night time for a night cap. Actually, what we call the midnight snack. Liking to eat is actually associated with pleasure derived from eating, and actually mediated through opioid and cannabinoid receptors. And this is actually responsible for our preferences in the food that we eat, and can explain why we prefer certain restaurants or shops to buy food, actually. So that's the thing. Now, the third one, so that's homostatic, all right, your ghrelin. That's your homostatic eating based on hunger, all right? And these are actually the polypeptides and the hunger by ghrelin. So role of the brain, the controlling eating, your homostatic, and your hedonic. So with hedonic, you always want, there's the liking by the opioid and cannabinoid receptors. Your role of the brain in controlling eating right now lies on, of course, your executive function, which is the decision to eat, mediated primarily by the prefrontal cortex. So this region right now of the brain is the site of action for behavioral interventions, actually, which we can use to control whether we give in. Do we want to give in to the food that we really wanted to eat? That is an impulse, actually, the impulse to eat, which is dictated by other regulators for appetite. So this is behavioral interventions that we want to empower sustainable behaviors in controlling eating. That's the reason why we have this lecture. So we can really do enhance executive function. So the long-term weight loss is very, very challenging. Look at this particular lecture, this particular slide. It's a meta-analysis consisting of various weight loss interventions, which is without a doubt that some form of weight loss can be achieved. However, universally, what can be noted that after any intervention, whatever you do on your weight loss program, weight regain is sure to follow. That is the yo-yo effect already. The reason behind this is that the body adapts to any form of weight loss. In a primal survival mechanism, the body thinks that the patient is trying to lose weight, which is starving. Hence, it adjusts to its hunger and satiety hormones. It will increase now the ghrelin, it will decrease in satiety hormones, and of course, also it will reduce the energy expenditure, using less amount of energy for daily processes to ensure that whatever weight that is lost is regained by the person. But usually, this becomes the source of frustration and depression. So, among patients that is trying to lose weight, wherein they feel that it is their fault, but actually, it is their fault why they are regaining weight, but when in fact, actually, it is the body counteracting whatever intervention that is being done in order actually to regain weight. So actually, a systematic review of obesity treatment studies where actually participants successfully lost weight demonstrated a trend of weight regain towards baseline again during a follow-up, and suggesting that weight loss is actually difficult to maintain over time for a majority of participants. And actually, almost all of us are victims of this, actually, because metabolic adaptation makes maintaining weight loss challenging, and metabolic adaptation is a physiological process wherein it is characterized by changes in the levels of appetite regulating hormones, actually, and a decrease in the energy expenditure. So when weight loss, actually, dear doctors, when there is weight loss, the energy expenditure that is associated with the resting metabolic rate and metabolic rate with activity decreases. So because less work should be done to maintain homeostasis or to move the body. So I hope you understood that really well. So targeting the appetite wherein the regulation for this is the key. Alright? So this is actually the key for effective weight loss. So augmenting any intervention with pharmacotherapy should target appetite regulation. It has to be like that, or else your weight loss will be going in vain. All right, without appetite regulation, weight regain will always follow any form of weight loss management, even for those who undergo metabolic surgery, actually. So we don't want that to happen. So consider this patient with obesity. Later on, I will also show some of my patients, actually. So this is actually JR, single, 39 years of age, an architect, so on a sedentary lifestyle, 5'10" in height, 230 pounds, BMI is 30 kilograms, so that is actually class 3 rank. He has GERD for 9 years, he is a non-smoker, social drinker, he eats 3 meals a day consisting of really everything, rice, pork, and everything, has frequent PM snacks, and of coffee, milk tea, and pastries, so high caloric intake, alright, has tried fad diets in the past with some degree of weight loss, but yet the activity behavior is always sedentary. Alright, so that's his lifestyle. So ongoing project at present, so it's sedentary. He lives alone in a condo, has been lifting weights and so forth. His blood pressure is actually 120 to 130 for the systolic, alright, and then for diastolic, it's 80 to 90. So the blood pressure usually is 130 over 90. So the weight history is this one. From 2010, 2011 until 2020 present, he started to increase weight, 140 pounds. And then, of course, lost 20 pounds in the second year, regained weight again in the third year, and then he started intermittent fasting in the fourth year, has regained weight again in the fifth year, and then on the seventh year, started on keto diet, and at present, actually last year, on community quarantine, voila, weight increased to 230 pounds. So it's a very, very sad thing, no matter how hard he wanted to. That's the reason why, alright, I'm here to actually introduce to those who haven't heard this yet, the value of Liraglutide, 3.0 milligram in obesity management. And with that, actually, this one I want to concentrate on this particular slide. So what is Liraglutide? Alright, so Liraglutide is a once daily human glucagon-like peptide 1 analog. It actually came from Saccharomyces cerevisiae, and actually it's a usual form for more than 50 years, an ingredient for some medicines, for beers, and so forth. Here we can see the amino acid structure of Liraglutide, a human GLP-1 analog side by side with native human GLP-1. You'll see that in the plasma, the native GLP-1 has a short life of around 2 minutes as it is rapidly degraded by the enzyme peptidase 4, making it unsuitable for clinical use. So Liraglutide shares the 97% amino acid sequence identity with the native GLP-1, but however it has been modified to extend the half-life, and these changes include, let me tell you, an attachment to the C16 fatty acid side chain linked via their glutamoyl spacer at the position 26. And of course, the replacement of the lysine with arginine at position 34, providing only one binding site for the C16 side chain. You will see that here. And of course, these modifications right now allow the Liraglutide to bind to albumin, increasing the resistance to your peptidase 4 degradation, and thus reducing the renal clearance, thereby extending the half-life to 13 hours. And this is what we really needed, which allows once daily dosing only. So this reduces actually the human hunger. So you will see here, actually this is so nice. This is actually a conducted study by Setcher and his associate. It's a series of in vitro experiments in rodents to determine the sites and mechanism of action of Liraglutide in the central nervous system. So there's fluorescence labeled Liraglutide that has been shown to bind to neurons with the arcuate nucleus, or the arc. A simplified schematic of 3 neuronal populations in the arc is actually shown in this slide. And you will see here that the GLP-1 receptor has actually what required for this Liraglutide binding, and the staining was not seen in the arc neurons of the GLP-1 receptor knockout mice, but there's electrophysiological experiments revealing that the GLP-1 directly stimulates pro-opiomelanocortin, cocaine, and of course amphetamine regulated transcript neurons. This is actually the long term for your POMC, and that is the one that you see here. Alright, then this one increases the satiety, but this one now, that's the green one, alright? So this one further indirectly inhibits your neurotransmission in neurons, expressing now your neuropeptide Y, which is shown in red. Okay, that is your NPY via your GABA aminobutyric acid dependent signaling. That's your GABA shown in blue, reducing now the hunger. That's the reason why. So this data suggests that the GLP-1 receptors of your POMC, alright, and it's a regulated transcript expressing neurons of the arc, may mediate now the Liraglutide induced weight loss, and which is really, really nice. So for your Liraglutide 3.0 rather, food intake resulting into weight loss. You will see here that like natural GLP-1, alright, that actually increases your insulin, decreases your glucagon. This is liraglutide activating specific areas in the brain involved in the regulation of appetite and weight loss. And of course, food intake in the long run. It decreases hunger. It increases fullness. You will see it here. Increases satiety, which is really, really nice. You always feel that you are not wanting to eat. You're not hungry. Food intake does is increase, so it reduces the hunger. Okay, which is very, very nice. So this is actually a trial scale obesity and pre-diabetes. Of course, we wanted to do the medical evidence base. So for the Novo Nordisk, Don did rather the scale trial, which is for obesity and pre-diabetes, for hypertension, for sleep apnea, and also for mental capacity. So let's see. Okay, so this one now, actually, this is your scale obesity. So scale obesity for obesity and pre-diabetes was a 56-week randomized double-blind, placebo-controlled, multi-center trial in adults with obesity more than, all right, the BMI of more than 30 kilogram, or overweight of more than 27 BMI with comorbidities and without diabetes. So the study participants actually were randomized 2:1 to receive liraglutide 3.0 milligram or the placebo and stratified according to pre-diabetes status at baseline. So at 56 weeks, you'll notice here that the participants without pre-diabetes who were receiving liraglutide 3.0 were re-randomized, which is now 1:1, to either continue to the liraglutide 3.0 or to receive the placebo for further 12 weeks. So you'll see here that the primary endpoints were change in body weight from baseline, number of participants achieving more than 5% weight loss, number of participants achieving more than 10% weight loss, and we really love these results. Actually, the key secondary endpoints including changes in glycemic control variables and cardiometabolic risk factors and safety endpoints. So you'll see here that according to the ADA criteria, with participants needing to have at least one of the following: impaired fasting glucose, impaired glucose tolerance, and an HbA1c, glycosylated hemoglobin of 5.7 to 6.4%. Okay, so now this one now is so your liraglutide 3.0 provided sustainable weight loss of 9.2% over 1 year on this particular patients on scale trial for obese and pre-diabetes. 9.2% weight loss with liraglutide, that is versus actually 3.5% on placebo. Now, 1 out of 3 patients lost more than 10% weight loss with liraglutide, 3 milligram over 1 year. So that is really, really nice. 1 out of 3. That's more than 10% for over a year. So 63% of patients using liraglutide versus 27% using placebo. At least 5% weight loss, which is very big. That is actually then 14% of patients using liraglutide versus your 4% using placebo, more than 15% weight loss. And we really, really like that. Now, another scale design, which is now obesity and pre-diabetes again, but this time now 160 weeks and using 3.0 milligram. So as we already discussed, scale obesity and pre-diabetes, randomized, double-blind, placebo-controlled, multi-center, alright, with obesity or overweight, with comorbidities, and without diabetes. As shown here on this particular slide, patients were stratified according to pre-diabetes status at screening and defined according to the ADA criteria. So these criteria will be described in more detail on other slides, but for participants without pre-diabetes at screening, the treatment duration was 56 weeks actually. And however, for participants with full diabetes, actually, you will see here that, or with pre-diabetes at screening, the full trial duration was 160 weeks on treatment followed by 12 weeks. Okay, 12-week off drug follow-up period. So the primary aim of collecting the 3-year data was actually to evaluate whether liraglutide 3.0 milligram could really delay the onset of type 2 diabetes. And look at this, 7.1% weight loss with liraglutide 3.0 versus your 2.7 on placebo. 1 out of 4 patients lost more than 10% with liraglutide over 3 years. That's actually 1 in 4 patients, and 50% of the patients using liraglutide 3.0 versus 24% on the placebo. At least 4% weight loss, 5 weight loss. Now, 11% of your patients using Liraglutide 3.0, all right, that's versus your 3% rather of the placebo that has more than 15% weight loss. So, really, the benefits beyond weight loss, actually, which is really, really nice. Okay, so the benefits with this beyond weight loss: 69% patients with prediabetes return to normal glycemia after 1 year of treatment, 80% reduction in risk of progression to your type 2 diabetes in 3 years' time, significant reduction in systole and diastole. So that is actually after a year of treatment compared to placebo. But I'll show you my results in a while. Significant improvement of lipid levels, including total cholesterol, your LDL, HDL, triglyceride, after a year of treatment compared to placebo. And of course, significant improvement in your quality of life scores among all aspects after 1 year of treatment compared to placebo. So this is actually, again, now another trial design, which is scale maintenance. And this scale maintenance actually is weight maintenance with Liraglutide 3.0 milligram after LCD-induced weight loss. Here we can see the trial design scale for scale maintenance trial for 56 weeks, randomized, double-blind, placebo-controlled, multi-center. So this was designed to investigate the potential of Liraglutide to maintain prior diet and exercise-induced weight loss in adults with obesity of more than BMI 30 or with overweight BMI 27 more than with comorbidity. So participants were actually first treated with a low-calorie diet and encouraged to undertake 150 minutes of physical activity per week during a variable length run-in period between 4 and 12 weeks. So the participants here, you will see that they achieved more than 5% weight loss during the run-in period, were then randomized 1:1 to receive either Liraglutide 3.0 or placebo for 56 weeks. And all individuals received a 500 kilocalorie per day deficit diet and exercise program. So after 56 weeks or week 56, there was a 12-week off drug follow-up period. So 3 co-primary endpoints were assessed hierarchy at 56 weeks. So mean percentage change in fasting body weight from the time of the randomization, that's first, and the proportion of patients maintaining the more than 5% decrease in weight achieved during the run-in, and the proportion of patients who lost an additional more than 5% of their fasting body weight after randomization. Very, very nice result. So this slide shows that further weight loss following a low-calorie diet and physical activity is really, really good. So there's a primary endpoint, mean percentage change in the body weight. During the run-in period lasting up to 12 weeks, mean weight loss of 6%, you will see it here, was achieved in both groups. Going further, the weight profiles of the two groups diverge after randomization to Liraglutide 3.0 or placebo. At week 56, body weight had continued to decrease in the Liraglutide 3.0 milligram group with an additional mean weight loss of 6.2 over the treatment period. So if you compare it, body weight was maintained in the placebo group, but it did not decrease. So during the off-treatment follow-up, both treatment groups gained weight. All right? So that's it. Look at this. So 6.2% for those at 56 weeks with Liraglutide, and placebo minus 0.2%. So maintaining the weight loss is really after a year of treatment at week 56. Now this left graph, you will see it shows the proportions of individuals maintaining the weight loss achieved during the run-in period in two groups. 81% treated with Liraglutide achieved this compared with 49% in the placebo. But weight regain was also analyzed as shown in the graph on the right. And actually, significantly, fewer individuals in the Liraglutide 3.0 group gained more than 5% of their weight, actually. So that's randomization body weight compared with placebo. So achieving your additional weight loss after 1 year, the third co-primary endpoint related to the proportion of individuals who lost 5% or more of their body weight, which is really nice after randomization, that is, in addition to the weight loss during the run-in phase. So again, this is significantly favored, all right, favoring your Liraglutide 3.0 over placebo because it's big. Actually, it's 50.5% versus your 21.8% respectively. So more than 4 times as many patients treated with Liraglutide 3.0 achieved weight loss of more than 10% after randomization compared to placebo. So what is the safety summary of their scaled clinical trial program? It's really actually, this slide summarizes the key safety issues which are 3.0 on all the identified scale trials. So across the trials, the major adverse events are actually the gastrointestinal ones were the most commonly reported. And then most events were actually transient only, mild or moderate severity, and resolved while individuals continued liraglutide treatment. So in the scale obesity and prediabetes trial, weight loss observed with the liraglutide 3.0 was not explained by the occurrence of gastrointestinal adverse events. So if you'll notice, if the dosage is increased, the adverse effect of the gastrointestinal is actually not evident anymore. So across the scale program, increases in the resting heart rate were in line with the other GLP-1 RAs and were observed with decrease in the blood pressure and lipids. In a post-hoc analysis of the scale program, treatment with liraglutide 3.0 milligram was not associated with excessive cardiovascular risk. So there's also the LEADER trial, wherein a cardiovascular outcome trial liraglutide, dose up to 1.8 milligram only, significantly reduced the MACE, wherein the first occurrence of death from the cardiovascular causes, non-fatal MI, non-fatal stroke, in individuals with type 2 diabetes and high cardiovascular risk when compared with placebo. So actually there's no imbalances between the treatments that was observed in anxiety or depression based on adverse event, even reporting a mental health questionnaire. So, but however, we've seen that a small imbalance in suicidal ideation as adverse events not consistent actually captured by the CSSRS. This was actually noted and is not yet and it's actually unexplained. So similar to other centrally acting anti-obesity medications, patients treated with the liraglutide 3.0 should be monitored for depression or suicidal thoughts, and a treatment should be discontinued if the symptoms develop. So what I see here is that actually the most common is nausea over time, wherein the percentage of individuals with ongoing nausea by week in treatment, it resolves actually in 18 weeks. So this is an observed mean data for the safety analysis set. So similar pattern was observed for individuals who experience diarrhea, constipation, vomiting, although with lower percentages of the individuals experiencing the events. So overall, 52 individuals in the liraglutide 3.0 group withdrew owing to the nausea. That's the number one, actually, the nausea. Compared with the 5 in the placebo group, individuals actually were randomized 2:1 to liraglutide and placebo. So your gastrointestinal disorders, 93% of which were mild or moderate in severity, were the most common side effects in the liraglutide 3.0. So how do we really manage obesity right now during the time of COVID-19? All right. So how do we really manage? So this is actually a very, very good slide to partake now. So let me give you some of my cases. This is a case of a 39-year-old male, an IT project manager, office worker, who has bronchial asthma since childhood, also had hepatitis A and dengue fever mid-20s, an alcoholic drinker. He eats meals at 2 times a day, complete food groups, all without restrictions actually. He is moderately active, but what is nice is that he exercises 30 to 60 minutes, and that is twice a week. All right? But his blood pressure is not nice. It has high systole and diastole. That's 110 over until 150, and it's 80 until 100. So really high. He has dyslipidemia 4 months ago before liraglutide treatment. So how severe is the patient's obesity? He's really stressed out from work, big belly on some quadrants, extra love handles. So he has hypercholesterolemia, hypertension, but he insists of not using any medications. So his weight goal actually is 5% weight loss every 6 to 8 weeks and 10% weight loss after 20 weeks and beyond, even with this particular comorbidities. So the option is that the best treatment is that medication for hypertension and hypercholesterolemia, but the patient doesn't want this. His decision was to use the liraglutide and the right timing because Saxenda was introduced in the country last year, and it was a more holistic approach that is weight management along with improvements on comorbidities, thus more target specific. But I still tell the patient to have his checkup with the cardiologist, of course, for his hypertension and the dyslipidemia. So this is a patient before 190 pounds. After 6 weeks, 8 weeks actually is 168 pounds already. Look at how the contouring from the lab handles and how this actually are seen, all right? You really see the big difference actually. Very, very nice result. At the sides, all right? Now we can see some of his abs. What is nice on this patient is that, yes, there's no restriction. He eats 2 times a day with no restriction, but he really exercises well. And that is actually the definitive course with liraglutide. All right? You have liraglutide, exercise really well. You can still eat, but it's better to do your fasting, your intermittent fasting. Now, another case of a postpartum 27-year-old female. 5'2", 134 pounds before, alright, but after liraglutide, she drops to 122 pounds, alright, just in 6 weeks' time. Medical representative, field worker, Gravida 1, Para 1, social drinker during college, again, intermittent fasting 2 times a day, no restriction on food, but she exercises twice a week, 30 to 60 minutes. Normal blood pressure, uneventful laboratories. But she has, just because it's her 9th month, so extra big belly on some abdominal quadrants. Non-lactating already. Of course, there's love handles, alright? 5% weight loss every 6 to 8 weeks, no comorbidities. The decision is, of course, target-specific liraglutide. This is her photo. 134 pounds before, after is 122, and I like the contouring actually. Look how the belly was gone. Alright, after 8 weeks. 8 weeks to 12 weeks to 4 months. Alright, at the back, lessened love handles as well. On the sides, really nice. She's getting there. Actually, she's getting there. Alright, before and after. She's really getting there. Alright, another case, 45-year-old female, physician, hardworking, Gravida 1, Para 1. Alright, palpitations with caffeine. Alright, drinks, alright. And of course, she has endometriosis, myoma, and polyps. Non-alcoholic, non-smoker, 2 main meals per day without restrictions, but she never eat rice. She doesn't like rice. All chocolates, ice cream, cake, all the sweets in the world. With a wide area of work, very sedentary, of course, but not much. Because she moves around, no exercise, but she stretches a bit. Her blood pressure is 110 until 130 when she's, and then over 80 until 90. All right, so there's a bit increase of liver enzyme because she got so big in the past 7 years. But normal glycosylated hemoglobin. All right, slightly elevated lipids. All right, level 1 overweight. Gained massive weight at 39 years old, present reaching 73 kilogram at 45 years old right now. Patient hopes to lose weight, about 40 pounds. That would be her ideal BMI, of course. Address slowly her comorbidities, hyperlipidemia and fatty liver, maintain the normal blood pressure, go back to mesophar body that she wants. And of course, she is taking statins, but just 2 weeks, alright? Liraglutide 3 mg daily. Address the comorbidities, incline to exercise, manage eating habits, lower down on sweets and carbohydrates. This is the best treatment approach on this particular patient. That patient is actually me. Alright? On December 2019, was my photo until March 2020 before the lockdown. Then I started the Saxenda liraglutide in April 2020, and this was me on my 6-month journey. I think about 20 pounds to 25 pounds lost already, 9 kilogram down, effortless without exercise. Alright, a 6-month journey, and from size 12 became size 8 already. So getting back, because I was just size 4 or 6 before, even if when I gave birth already. Okay, so the patient outcome, so very, very nice overall. Initial goal was achieved. Body physique result was salutary, especially from the flabby area. Cellulites decrease. Because it will really be decreased because the main function is on the visceral fat first. And then after all the visceral fats are taken care of by the liraglutide, it will now go straight to the cellulite. So whether you like it or not, your clothes really will, all the cellulites are really, really handled really well. And you're going to have your decrease on the size of your clothes. Loose and compact and edematous fat areas, right? Address their hyperlipidemia and diastolic hypertension. Cost effective, especially when it becomes 3 points. The problem is actually it's cost effective, but the problem is when it becomes 3.0 milligram daily, and we can discuss more during the Q&A. The side effects are not the same from one patient to another, which is of course serves an advantage. A lot of my patients, some of them don't have side effects totally. All right, mine was constipation. Some patients are nausea. All right, another patient had diarrhea, but everything was transient. Some patients forget the injection time, morning versus night, so I tell them to do the nighttime administration. Patient outcome results are real. This is really actually for real, especially if patients adhere to the protocol. Fast, sustainable, and it's really dependable. What I've seen is that no yo-yo. All right, so I'll explain that in a while. Injection and same site may produce wheal formation. It happened to me. So you have to really inject on some areas, that not only on that particular area all the time. You have your belly, you have your arms, you have your thighs. Make sure to observe aseptic technique. Topicals, anti-infective, anti-inflammatory. If you get to have this rash for that, cold compress, then warm compress. Safety, sustainable manner of losing weight is the overall value of the liraglutide for the patients. Slowly but surely, dependable, worry-free, medical evidence-based studies, and multivital results for the past 10 years, and no yo-yo results. So this is actually liraglutide 3.0. The general protocol is to start your patients for the first 7 days on 0.6, and then second week, zeroing into 1.2, then 1.8 on the third week, and the fourth week is 2.4, and that is on the fifth week onwards is the 3.0. This is where it becomes a bit costly per pen. Alright, because the pen right now at week 5 onward becomes 6 days only. Alright, 6.5 days. So you really need to tell your patient that is the scenario, and it will depend. Some would have it for 6 months, 8 months, and some of the studies that were presented rather in the scale trial, some were until 2 years. And well, in fact, really manage the weight until 100 pounds actually. So, liraglutide delivers significant and sustained weight loss with consistent improvements in cardio metabolic risk factors. 9.2% average sustained weight loss was seen for patients who completed 1 year of treatment. 69% of patients with obesity and prediabetes returned to normal glycemic status, which is really nice, after 1 year of treatment. Just like my patients, just like me actually. 80% reduction in the risk of progression to type 2 diabetes, significant improvements in blood pressure and lipid levels after a year of treatment. But in fact, on my patient, it was just on the 3rd month actually, control on their systolic and diastolic hypertension. Significant improvements on the quality of life, notably physical function after a year of treatment. So in summary, obesity actually is a chronic medical disease and a global pandemic, and 4 out of the 10 Filipinos are either overweight or obese, and not just in the Philippines, around the globe. So we need a lifestyle modification, which is the primary intervention for patients with obesity. But however, most people will experience weight regain within 2 years. So we need something that is sustainable for us to battle the weight regain, the yo-yo, because that forms part and parcel of more depression on the patients trying to lose and maintain the weight. Alright, the brain is responsible for maintaining the weight set point and metabolic adaptation. It all comes into play in the phase of weight loss that promotes the weight regain. So your liraglutide is a centrally acting drug which affects the centers of the brain involved in hunger and satiety, resulting into weight loss. The scale maintenance trial has shown that liraglutide on top of diet and exercise can prevent weight regain, providing an additional 6.2% weight loss compared to placebo. And then with that, I thank you very much for listening to this lecture tonight. Thank you very much.